50% of prostate biopsies are unnecessary. Today, doctors use a specific imaging protocol to identify low-risk patients before a needle is ever drawn. Prostate cancer is the second most common cancer among men in the United States. Historically, screening relied on the PSA blood test, which measures prostate-specific antigen. If those levels came back high, the standard response was to order an immediate biopsy. This created a blind diagnostic process. Urologists would scatter needles throughout the prostate in a uniform grid, hoping that a random strike would eventually hit a hidden tumor. This scattershot method often missed small, aggressive tumors located between the needle paths. Simultaneously, it frequently struck slow-growing, harmless anomalies that never would have posed a threat to the patient. When these harmless tumors are found, it often triggers unnecessary panic. Patients end up undergoing aggressive surgery and radiation to treat low-risk issues that likely would have remained stable for their entire lives. To solve this, doctors have adopted Multiparametric MRI, or mpMRI. This technique uses a combination of magnetic fields and radio waves to map the prostate gland digitally rather than probing it physically. Transitioning to an MRI-first approach allows for a precise risk assessment. By mapping the anatomy in high resolution, doctors can identify the exact location of a threat before any physical intervention occurs. Multiparametric imaging evaluates the prostate through 3 distinct biological lenses. By layering these different types of data, radiologists can isolate cancerous tissue with high precision. The first lens is T2-weighted imaging, a scan that measures the water content of the tissue. Healthy prostate tissue is water-rich and appears bright on these scans. This image shows a T2 scan, where a tumor has displaced the natural water content. Radiologists look for this dark smudge, often called the erased charcoal sign, which indicates a potential lesion in the central zone. The second lens is diffusion-weighted imaging. It tracks the movement of water molecules. Dangerous tumors have densely packed cells that block this movement, causing restricted diffusion. On this DWI scan, the cancerous area glows brightly, confirming the dark smudge seen earlier. The final parameter is dynamic contrast-enhanced MRI, monitoring blood flow. A contrast dye is injected to map absorption. Aggressive tumors build abnormal blood vessels that absorb the dye much earlier and more intensely than healthy tissue, causing the suspicious area to light up. By stacking these 3 metrics, tissue density, water restriction, and blood flow, doctors can identify the digital footprint of a cancer while ignoring the harmless shadows that often confuse traditional screening. Raw MRI data is difficult to use if doctors interpret the same shadows in different ways. To create a universal standard, the medical community developed PI-RADS, the Prostate Imaging Reporting and Data System. The PI-RADS scale assigns a score from 1 to 5 to calculate the likelihood of a clinically significant cancer. This is generally defined as a cancer aggressive enough to require active treatment. Scores 1 and 2 represent low risk, indicating normal tissue where a biopsy isn't necessary. Score 3 is an intermediate result. In this gray area, urologists use secondary factors like PSA density to decide if a biopsy is worth the risk. If you are interested in how precise data is helping patients avoid invasive procedures, consider liking this video and subscribing for more medical breakdowns. A score 4 indicates high risk, meaning a distinct lesion is clearly visible and likely contains aggressive cancer. Score 5 is the highest risk, reserved for tumors larger than 1.5 centimeters, or those that have broken through the prostate's outer capsule. These strict criteria ensure urologists focus on life-threatening, aggressive tumors while filtering out the slow-growing anomalies that don't require intervention. A PI-RADS score of 4 or 5 identifies a high probability of significant cancer, but it functions as a visual guide for the urologist rather than a final diagnosis. This data is used during a fusion biopsy. Doctors overlay the 3D map from the MRI onto a live ultrasound feed of the patient's prostate. This fusion technique allows the needle to target the specific millimeter of a suspicious lesion, reducing the risk of missing a tumor that a blind biopsy might overlook. However, the effectiveness of this entire system depends on image quality. Currently, over a third of prostate MRIs are hampered by insufficient clarity. Patient movement, bowel peristalsis, or poorly calibrated equipment can blur the scan data. When the image is unclear, doctors often see equivocal results, which can lead back to the same unnecessary biopsies the technology was meant to prevent. Because the PI-RADS system relies on high-resolution data, choosing an experienced radiology center and following all patient preparation instructions is critical. Implementing standardized imaging metrics ensures urologists can act on specific, verified targets. In the effort to improve cancer outcomes, high-resolution data remains the most important tool for separating life-threatening disease from harmless anomalies.